Okay, so we're going to finish up the lectures before the lab, and I'm just going to talk a little bit more about the same topic using a combination of microfat and nanofat for facial rejuvenation. Again, we don't use these fat grafts anymore because they don't survive, and so we really shifted to using the microfat technique and putting the little particles in these little tunnels so that the cells can revascularize. And we've shown scientifically and clinically that this technique works very well. And again, the harvest is pretty much the same, but when we get to the processing, that's where the difference comes in between the microfat and the nanofat, and then the injection process also differs depending on the areas that we're treating. So again, when you centrifuge adipose tissue, which we do, I would say on at least half of our facial cases, if not more, you get the oil at the top, and then the tumescent fluid at the bottom, and then the adipose tissue in the middle. And we use these blunt injection cannulas for injections in the face, which is they've been really a game changer for us because it's such a vascular area. The needles just don't work very well, especially in the deep tissue. So this just shows the blunt injection cannula. This is a similar slide that I showed this morning. And you can see that the patient is awake. There's no anesthesia blockade whatsoever, just a little bit of a wheal on the skin. And you can get these cannulas to really cover a lot of ground without having any bleeding, and the patients are quite comfortable during the procedure itself. And again, this is just another example of showing how you can go from the right side of the face all the way across to the left side of the face, cross the midline, and not have any issues with any bleeding or hematomas. And then this is a microfat transfer. This is a case of a patient, a smoker, who is severely deflated. We were using the microfat for a while, even in the lower lids, but we did come across problems. Thankfully, this is not a patient of mine, but this is a problem that we saw with using microfat and large particles, relatively large particle size for the lower lids. So when we have thin skin and we don't have a lot of subdermis, we're injecting into the dermis itself and really not filling contour irregularities. So basically, you have microfat because you're harvesting adipose tissue through small cannulas, and then what turns microfat into nanofat is running it through these three serially smaller lure-to-lure transfers, the 2.4 millimeter, and then the 1.4 and the 1.2. Interestingly, we tried to eliminate the 1.4 centimeter and just go to the 1.2, but we found that the tissue flows better when we use all three sizes for the emulsification. I'm not sure if it's just the number of passes or that extra variation in diameter. But basically, you're getting a lot of the exosomes and cytokines and things from the cells themselves. So the nanofat is not a very cellular product. It's more of a liquidy product with lots of different regenerative properties. Microfat, which is now going to be emulsified through these serial lure-to-lure transfers, and you can see that we go from the 2.4. It is quite difficult to kind of push the fat through, and some patients have more fibers in their fat than others. But once you get it to flow pretty smoothly with the 2.4, and we go back and forth a few times, it does eliminate the fibers. Sometimes we do have to actually open up the lure-to-lure transfer and kind of fish out some of these particles, similar to what Dr. Tonard and Dr. Perpel do when they actually just remove them directly on top of the cloth. We actually have to wait until we get the clog, and then we pull them out. So I think that their method may be a more efficient way to do it. And then we put the emulsified adipose tissue through the transfer, and again, you can see the milky, lighter colored syringe is the one with the emulsified fat, and then this is the standard microfat, just immediately following a harvest. And again, this is a centrifuged nanofat versus centrifuged microfat. And you can see that this is really the only adipose tissue is really here at the bottom, that all of this is liquid. And when we do combined cases with the musculoskeletal doctors, the orthopods look at this oil, they get very, very scared. And so we really have not used nanofat for MSK indications. But for some reason, in the skin and in the face in particular, this fluid has lots of good stuff in it. We're really trying to characterize exactly what is in there and how does it work. But this is really shows that there's not very much fat in the nanofat. And you can see that the consistency is still a little bit lumpy with the microfat versus the nanofat, which is very, very smooth in consistency. And it should really just drip out of a syringe. So that's the consistency that we want. And from Dr. Tenard and Verpel's article, you can see this is a stain showing microfat. You know, this is the stain highlighting the fat tissue, and as you get down here to nanofat, you see that there's almost no staining, meaning that there's very little adipose tissue in the nanofat itself. And then this is from their article showing the injection into the dermis, and then their result with the lower eyelids and with the perioral area. So the more resizing, I guess I should say one important thing is that the FDA, at least here in the US, the FDA does not like the word emulsification for some reason. They love the word resizing. So we are now not emulsifying anymore. We are now resizing. Okay, so anybody from the FDA knocks on your door and says, "Are you emulsifying?" Nope, we're just resizing. Okay, so, but the more resizing and the more emulsifying you do, the less microfat you have and the more nanofat you have. So we want to try to help clear up the confusion in that regard. So microfat is thicker consistency. We are harvesting it through larger cannulas, and we have more end product with microfat. So when you get down to nanofat, you lose a lot more volume. So the microfat is very good for filling. It has very good filling capacity, whereas the nanofat does not. So it's a thinner, more fluid-like consistency, and we're injecting it through smaller cannulas and even small gauge needles into the tissue itself, again with less end product. So we were talking earlier with some of the group about hair restoration and how much product do you need to do a whole scalp. So with a with a small amount of tissue, you can't treat a large surface area. So you either have to harvest a lot of adipose tissue or do a smaller area. So these are some clinical examples. This is again a case of Dr. Coleman's. This is just microfat, but this is a minimally invasive type of a treatment compared to an open surgery and a free flap and things like that. So this is a nice option for the patients and for us as doctors. So this is a case that most doctors did not want to tackle, and Dr. Coleman did a nice job with the microfat grafting here. This is a case where I used, again, combination of microfat and also nanofat for tear trough correction. And again, these are much less invasive treatments than blepharoplasties, and quite frankly, blepharoplasties would not be the appropriate operation for this deformity anyway. So we're using the nanofat in the more superficial tissue and helping with the dyschromias and the discolorations, and as Dr. Tenard said, shifting gears into more of the regenerative capacity of the nanofat, and then using the microfat to fill in the contour for the filling, since the nanofat does not have any capacity to fill. And this is another case similar, showing this is mostly microfat and not nanofat here in this particular case. We needed more structure. This is this lady I showed this morning. She's a smoker. I put 45 cc's of microfat around her mouth. This is not a nanofat case by any means. This is all microfat. And again, this is not something that you could achieve with an operation. You don't want to pull tight and distort the mouth. So it's a less invasive option and very, very effective for filling. But this has nothing to do with nanofat. This is all microfat in this case. And I really, quite frankly, I kind of panicked after the case and thought, oh my gosh, I put 45 cc's in her perioral area. And when she came back, I was like, oh my God, I was so relieved. I thought she could have used another 20 cc's. I just didn't have the guts to do, 65 cc's in the perioral area. And you can see this is, again, nothing to do with nanofat. This is all about microfat. And less invasive facial rejuvenation. This is face, eyes, neck that I did, and this is also did microfat in the areas of the nasolabial folds in the perioral area, and then did a nanofat treatment in the area of the lower lids. And you can see that the consistency of the skin is definitely improved, and this is a result that's actually 2 years out, so the patient's really holding up very well. This is this is a chin augmentation. Previously we would just cut into the intraoral, the gingival sulcus, and put an implant in through the intraoral approach, or cut on the outside. But you can get into the marginal mandibular nerve. You can cause numbness of the lower lip, and so this is a less invasive and a very effective way to treat microgenia. Again, this is not nanofat. This is microfat for structure. This is a lady that I did a facelift on, and then also did microfat in the mid-face and nanofat in the region of the lower eyelids. And this is another lady who had a similar treatment with nanofat in the eyelids and microfat around the face, as well as a facelift. So these are more invasive procedures, but combining that with the microfat and nanofat injections. And this is another case which shows we did microfat in the lips and in the mid-face, and nanofat in the eyelids, and also did a blepharoplasty and a face and a neck lift. And again, her skin just shows much more, much great improvement in the texture and the quality of the skin itself following the fat transfer procedure. So combining microfat and nanofat for minimally invasive facial rejuvenation is really, it's just a great tool. And we are using it for both cosmetic and reconstructive purposes, as you saw in the slides. Again, the harvest is similar, whether we're going to use microfat or nanofat, but the processing is where it differs and where we shift from filling to regenerative properties. The injections differ depending on the region, and we're going to go over that in the lab. And of course, it's indication specific, so you want to make sure that you're using the right tool for the right indication. So that's it. Thank you very much for your attention.